Well, good afternoon, everyone, and welcome to Samaritans First International Health Forum. We're delighted to have you join us once again, wherever you may be around the world. Really looking forward to our conversation today with Dr. Steffes. Before we get started, just want to remind you that we have the chat box to the right of your screen. As you join the forum, if you could sign in and just and indicate where you're participating from. And as always, we're going to start off in a word of prayer. So bow with me, please. Dear Heavenly Father, we just thank you for today. We thank you, Lord, just for the ability to engage in this conversation and to promote excellence in healthcare around the world for the sake of the gospel. We thank you for Dr. Steffes, who is joining us today. And Lord, we just pray that you just be present with us and just bless this interaction. And it's in Jesus' name we pray. Amen. All right. Well, I'm very proud to introduce today Dr. Bruce Steffes, whom I've known for many, many years. I remember I met Dr. Steffes first at Tenwick Hospital in 2002 when we were in adjacent homes on campus there serving at Tenwick Hospital. Dr. Steffes has done tremendous work for the sake of missionary medicine around the world. He is a global surgeon, entrepreneur, surgical educator. He's dedicated a tremendous amount of years to PACS, if you're familiar with Pan-African Academy of Christian Surgeons. Dr. Steffes has tremendous exposures to missionary operating rooms, both ill and well-designed operating rooms. And so he has a lot of insight that he's going to share with us today. He has worked in hundreds of mission hospitals and visited many, many more. Dr. Steffes has collaborated extensively with Charlene Gilbert, whom I know personally and have great admiration for. She's a registered nurse with over 40 years of international operating room experience to develop and present this material today. So, Dr. Steffes, again, we're delighted to have you here today, and I'll turn it over to you.
Thank you, Lance. It's a pleasure to be here. I'm glad everyone could join us this morning. We're going to be talking today about common mistakes in an operating room. Next slide, please. This lecture actually was recently given at the CMDE conference in Thailand, and many of you may have been there at that time as well. So next, please. I would love to have a financial conflict of interest at the present time, but not. This is a picture actually of an operating room that we designed in my hometown here in North Carolina many years ago for laparoscopy. And that was part of my interest. Prior to that, I had really gotten involved because I was a partner in a outpatient surgery center. And so one of our goals there was to design operating rooms that minimized expense, emphasized throughput, and high quality. So I've had several years of being interested in this. On the right, you'll see a picture there of Charlene. She has been absolutely invaluable in putting this together, and it helps if you've been in the operating room for 50 years and know what goes right and what goes wrong. Next, please. Here are traditional objectives, but one of the things that I'd like you to do is to look at your operating room after this lecture and realize that there's some things that could be improved. I want you to be able to take that and evaluate your OR. One of the things that we're going to talk about is the whole idea of workflow diagrams and instrument flow diagrams. And one of the other issues that is very important and a very common mistake is that in designing new buildings, we often turn this over to the architect and then just think that whatever he comes up with is the right thing. And that's not always the case, because the truth is that we are the experts in this. He's the expert in how to make it work for us, but we're the experts in what we want and how it should work and what the surfaces should be like, etc. Next slide, please. So we're not going to really talk about a given set of mistakes, but we're really going to talk about what it should be. If you're going to design your ideal operating room, what does it look like? And then you can find your own mistakes. Next, please. Here's a kind of a little quiz here for you. If you have the design principle that form should follow function, if that's true, which of the following persons is the least expert on the function of the operating room? The surgeon, the OR nurse, the anesthesiologist, the central sterile technician, or the architect? Well, as I mentioned earlier, we often turn this over to the architect, but it is really the first four who know what should work and how it should work and what are the issues. And the architect is the one who should take those dreams and those conversations and put them into some sort of functioning architectural structure. Next, please. Next slide, please. The most important thing, I think, in designing in an operating room is designing what you really want it to look like. And so the reality is that the surgeons that are at a given institution have their own preferences. They've known certain problems. You have to do all this before construction. My father was someone who did a lot of construction work, and he was always asking me to measure twice and cut once. Given that these projects are hundreds of thousands of dollars, if not millions of dollars, it's very, very critical that we measure several times before we finally cut so that we don't make mistakes. And so when designing this, we have to maximize the efficiencies of time, motion, space, and money, because those are all the things. Mission hospitals are a business. We don't like to think of it as that, but any inefficiencies in the way we approach patient care will cost money and will minimize the amount of money that we have to give charity care. So it's very, very important to plan, and then plan some more. The operating rooms themselves should literally reflect what you're going to do. When I walk in, I put something on the right or I do something on the left, and the operating room has to design that. A design has to reflect that. Next, please. There are multiple shareholders with this in these projects, and everybody has some differing expectations of that new operating room. The patient, of course, really is primarily concerned about the quality of the outcome. And so anything that has to do with the risk of infection or any other electrical problems is going to be something they're interested in. The hospital administrator wants to do this once. He doesn't want to pay money for it in the first place, but he realizes it has to be for a wide range of both open and minimally invasive cases. Ideally, if we design it well, it would require as few people as feasible. It's going to be easily updated. It's going to be easily maintained. It's going to allow and it's not going to be outdated in a couple of years. Now, the nurses themselves, they have a different appearance because they want the OR design to be safe and clean. They want to have sufficient sufficient housekeeping and cleaning between cases. They want to minimize time and motion. They don't want to run all over the entire suite trying to find things. They too want fewer personnel and rapid turnover. And of course, they want all the equipment to be such that requires little assembly, has standardized connections. It's simple to understand and use. And they've had adequate in-service training to actually know what the equipment is. Now, the surgeons want the OR design to really minimize all the distraction. We want to look at the patient. We want to look at what we're trying to accomplish and have everything else be relatively intuitive. So we want it to be ergonomically correct. We want adequate lighting. We want to be able to visualize. We do want rapid turnover. We want the latest of technology, and we want it to be well-staffed by well-trained professionals. Now, that's why there are debates over what the operating room should look like and how it should work. But you have to address all of these questions to go forward. Next, please. So one of the common mistakes that I see is that they will build an operating room. Let's say we're going to make it 4 rooms because that's all we can afford. But then in a very short period of time, it's no longer adequate. But because the design has been poor, there's no way to expand it in that particular area. So you end up having to tear it down or build a brand new, 8-room or 12-room later on. So one of the things I think is very, very important is designing how you're going to expand the operating rooms before you ever build the first one. If you think 2 is necessary, plan for 4 or for 6. Make sure that your electrical connections, your sewage connections, your traffic flow patterns, etc., will allow an expansion at a minimal cost in the future. I've built a fair number of buildings in the past, and the one thing that I've learned is that you never have enough office space, you never have enough toilets, and you never have enough storage. And that's definitely true in an operating room as well. One thing that is important to realize is that hallway sizes need to be at least 8 feet wide. Now, that seems to be a waste of space sometimes, But the truth is that a gurney is 7 foot something by 3. And so if you're trying to get 2 past each other in the hallway, or you're trying to store some equipment in the hallway, you need it wider than you expect. And of course, the other thing is that sometimes you have to turn the gurney 180 degrees, and again, need that. The other common mistake is that the ceilings are too low. As a general rule, 10 foot is the bare minimum that you should have. Now, one of the other mistakes that we commonly see is the fact that the workflow should reflect this whole concept of parts of the operating room being critical, parts of the operating being semi-critical, and those areas which are non-critical. And we'll talk about that a little bit more here in the lecture. But obviously, we do know that, for example, in the operating room, you're going to be wearing full regalia, and you're going to be masks, and you're going to be gloved, and that sort of thing, or at least a cap and a mask. But you would not want someone who is going to look into the room from the waiting room, and that would be a non-critical area. So the point that work and traffic flow and dirty instrument flow should be going in the right direction, and that these rooms and these areas actually communicate each other in the right order is important. Now, the other thing that's very important, I think, in helping the design is a concept of workflow diagrams. And these can be in general. These can be general for the whole operating room. For example, you need to have a pattern for your employees. How are they going to come in, and what rooms are they going to go to, and how are they going to get out? How are the patients going to come in, get around, and get out? How are the physicians going to come in, get around, get out? How are the instrument cleaners going to come in, get around, get out, without making traffic bottlenecks and making it efficient and reflecting this concept of critical, semi-critical, and non-critical areas? Next slide, please. In general, the other things you need to do is to consider if you're having air conditioning, you want to make sure that the airflow patterns are right. I have been in many an operating room where the air conditioning is actually pouring right into this open surgical abdomen. Not a good idea. We also realize, of course, that we are often in environments where the voltage is 220, but when we say it's 220, that means often that it's somewhere between 40 and 440. And so we have problems with all of our electronic equipment, our monitors, our cautery, etc., because we have to protect against both surge, the high voltage, and brownout, the low voltage. And actually, the low voltage is one of the more major problems. So one of the things that's very, very important is to sit and talk to an electrical engineer and see if you can isolate the electrical systems in these operating rooms so that neither surge nor brownout will wipe out all this equipment. As you know, we have a major problem with taking equipment from the United States, which is based for 110 volt, putting them in this environment, and then they fry very, very quickly. Another concept that's very important in terms of the instruments in the day-to-day basis is to make sure that you have not only an adequate water source, but that it is pure. It turns out that because of the issues of crystallization from the water, we want to have water which is either gone through a distiller or a reverse osmosis unit. This will actually keep your instruments cleaner, longer, and because there are no crystals in the instruments, then the bacteria can't hide there, and you actually have an easier chance of keeping it sterile. So looking at the water is a critical aspect. You know, ideally, you would have double doors going through from the OR into the sterile core as well, except for the sterile core, and so that there's plenty of room. Many times we put in small doors and then beat them up by pushing the stretchers through. Next, please. Now, the other thing you have to consider is where is the operating room going to be? We sometimes try to put all the operating rooms in one place, and that doesn't really work very well because of this sterile, non-sterile concept. An inpatient operating room really shouldn't have outpatients going in and out of it. That contaminates things too much. And so an inpatient operating room should really take this non-critical to critical transition very, very seriously. Whereas an outpatient operating room may be actually a separate unit or a separate set of operating rooms outside, but they're going to be handling, people coming in for cystoscopy or endoscopy or outpatient things. And so, again, an area where they have access to these semi-critical or non-critical areas may work best for them. And then, of course, if we're going to put an operating room in the emergency room, Many of those patients come in with sterility issues by their very nature. And so you might think very seriously about where you're going to handle trauma, where you're going to handle minor surgery, where you're going to do procedures like cast changes, INDs, etc., where you're going to take casts off. For example, you should really never take off a cast in an operating room. That should be taken off elsewhere, because all that dust is a real contaminant and a sterility issue as we go. Next slide, please. As I've mentioned, always more storage than you think. You have to remember, as you're planning this, you do need storage in the operating room, because there needs to be supplies there for both sterile supplies and non-sterile supplies. The sterile supplies might be your sutures or various equipment that is necessary in that room, and that may vary from room to room depending on how dedicated the use of the room is. But you also are going to need non-sterile storage in that you're going to have parts of the table, you're going to have straps, you're going to have blankets, you're going to have pillows, all that sort of thing. And what you should never do is have a closet area then in best practices that store both sterile and non-sterile supplies together. Next, please. Now we're going to talk a little bit more about this idea of workflow. When we do that, we have to keep in mind this critical, semi-critical, non-critical flow, and also just inside the room, how can I minimize the movement of equipment? You remember that when we clean the room between cases, we have to move every one of these pieces of equipment, and we run the risk of damaging them, slamming them up against the wall, knocking them over. And we just don't want to spend the time moving it. So those are all considerations that you're going to put into this. We've already mentioned earlier that we have various groups that have unique traffic flows. So they're really, the operating room, the central core part should actually be the kind of the center where all these various loops go on. Next picture. Next slide, please. Here's a drawing that came out of the anesthesiology journal that you can read a little bit more about. And this is what they're talking about. In an actual operating room, you see in this picture, they put the patient in the middle of the room, which honestly is not always the right place. But the various colors show what the anesthesiologist is doing, show what the circulating nurses, the scrub nurses are doing, what the physicians are doing. So making sure that you can locate things in areas that keep people in their parts of the room, minimize crossover, minimize difficulties is important. Next slide, please. Now here's a picture of kind of one of the fancy laparoscopic rooms that we're talking about, but it proves the principle. What you really need to do is that for any one of the common 10 or 15 operations that you do, you should be able to take some paper and draw this out and say, okay, I will, for this room, for this procedure, I always want the cautery unit back here. I want the anesthesiologist over there. I want the back table here. I want the irrigation basins here. And if you do that often enough, you often can find that you will place the operating room table in a different place, maybe, or design things differently. And this is tedious. This takes months and months of preparation to do this well. But if you don't do it well, you will usually regret it. Next, please. So, the critical areas, these are the areas where the utmost of sterility would normally reign. And they should be entered only from either another critical area or a semi-critical area. We're going to give you a picture later on of an operating room where you literally could have walked into the operating room from the outside, and that's just not acceptable. So what's in those areas? Well, certainly the operating rooms themselves. The scrub sink area is a little odd because sometimes we're there with a mask and sometimes we're there without a mask, but certainly if we're going into the critical area, this would be considered a critical area at that time. And then, of course, the central sterile core. One of the concepts that I think is very important is this idea of a central core and all operating rooms arranged around it. It's the most efficient way to store things, minimizes your movement during the operating rooms as well. And so the best operating rooms are going to have, at least in the operating room area, a peripheral hall, which is what you use to access any of the sterile rooms and eventually into the central sterile core as well. Now, in that central sterile core, you're going to have all sorts of things that the circulator nurse is going to have to get to. So that's going to be where your blanket warmer might be, your fluid warmer might be. You might have your endoscope cleaning equipment there. You might have your crash cart. You might have your flash autoclave in that one spot, and there's going to be a separation within that area between sterile and non-sterile storage of various supplies that are needed. Next, please. The semi-critical areas is where you really only have to have a cap and the scrubs, and so you can sometimes go into these areas from the critical area or from the non-critical area. For example, if you're going into the non-critical area to the semi-critical area from the employee lounge, that would be an example of a transition between the non-critical and the semi-critical area. And obviously, if you step out of the operating room and into this peripheral hall, that's semi-critical as well. And so here too, you may need sterile and non-sterile storage. This is often where you might find your case scheduling desk or your big whiteboard for the case schedule, all the external halls, the X-ray development, darkroom developer, all those kinds of things might be in this semi-critical area where you want people to be in a somewhat clean attire, but it's not absolutely critical that they be sterile. Next. In that same semi-critical area, the housekeeper's closet would be there because, of course, you will need janitorial services. This is where the nurses would have some access to some sort of flush hopper so that when they come out of the operating room with the fluids from the suction collections or the fluids from the back table, they have a place to flush these. You might have endoscope cleaning and storage here as well. And this is where the anesthesia lounge, the workrooms, et cetera, would all be in the semi-critical area. And of course, in the best of all worlds, you might actually have a separate room for anesthetic blocks, et cetera. And this would connect to the recovery room itself. Next, please. In the non-critical areas, this is basically the access to the rest of the hospital. So the head nurse's office might be on the unsterile hall. This is where all the employees would come in and they would go into the showers and the toilets and their locker rooms. The staff lounge, the tea break room is often a non-critical area. Housekeeping might be here for those parts of the OR that need a separate housekeeping janitor's closet. This might be where you store office supplies, et cetera. Next, please. This is where the pre-op holding area, so where the patients are brought in and where everybody gets to talk. We've all kind of seen this environment. This is actually a place that might have room for the family to wait at the bedside. They'll have toilets, et cetera. Pathology, if you're able to do frozen section, would be in this area, and the PACU would be considered a non-critical area, and everything that goes along with a post-anesthesia recovery unit. Next, please. Now, we get a little bit off this a little bit, and when we talk about the decontamination and sterilization area, it is obvious that if the best way to handle these instruments and supplies and so forth are to do this through a case cart system, a rolling cart that has sterile towels and drapes over it. Everything is put on the inside of it, and then everything is covered, because you're going to have to take this dirty stuff through the semi-critical area to the decontamination and sterilization area. Once you are in the decontamination and sterilization, everybody there needs to be wearing PPE if they're doing any kind of work, some sort of protective personal devices that keep them, gloves, aprons, masks, et cetera, so that this contaminated fluid doesn't make them ill in any way. Within this area as well, the nurses are going to be coming up to it. By definition, though, they are semi-critical. They will not enter into this area. They're going to empty the fluids into a flush hopper in that area, literally push the cart in the room, and nobody from inside the room comes out and nobody from the outside goes in during the time that we're trying to maintain this relative sterility differences. And so inside the room that's going to be decontamination and sterilization, there may be another flush hopper. You're going to have trash, and of course, this is where biohazard stuff is going to go as well. There's going to be storage for dirty linen. In cleaning the instruments, a couple of things are very, very important. We've already mentioned that this be water that has either been distilled or gone through reverse osmosis, because we don't want anything with minerals in it. You should have a true professional high-pressure water sprayer and sink system there so that you can clean the instruments with more force than would come out of a kitchen sink, for example. Ideally, you'd have pressured air, because one of the things that you want to do is to get the water and all the stuff out of any of the joints or any of the cracks in the instruments. And the thing that we would do then is once the instruments are clean, we would ideally put them in an ultrasonic cleaner after spraying. And once the cleaner has run, usually with a non-alkaline detergent and maybe with enzymatic component to it as well, then you're going to put it into a washer sterilizer that empties on the clean side. You should not be having a dirty or decontamination area that opens widely into a clean room. I see this done very commonly. It's not that there isn't a need to go between them, but as a general rule, it should be a wall partition between the two, and maybe a half door, a Dutch door. But what really should be coming is the dirty instruments go in one side of the washer sterilizer in the dirty room and come out on the other side in the clean room, where they can then be packed, stored, and do all the things that we do. So next, please. Now, when we're looking at the instrument handling area, we really talk about a dirty area, we talk about a clean area, and then we look at kind of a clean, sterile supply storage area as well. So we've just described the dirty area. These are where everything is coming in, covered with the blood and the various fluids, etc. And we've cleaned them up. Once they go through that washer sterilizer, they come out on the other side, and now they are clean. The instruments have been inspected for cracks and other issues on one side, but here is where they're very carefully inspected once again, determine whether or not they're sharp, whether they're clean, whether they're appropriate for use again, and then they're going to be reconstructed into some sort of pack. In this room is where the big sterilization units are, and they're going to be put into that sterilization unit, properly run, and then ultimately when the packs are dried in the autoclave units, they're stored in a sterile supply storage that has open access to the semi-critical areas, because this is where the nurses are going to come to get their instrument packs. Next, please. So how do you design some of these various areas? In the outpatient surgical areas, in the non-patient areas, I've got a list here of various things, and they're fairly obvious, but it's amazing how many times we forget them. So one of the things
apologies, I believe we're having some temporary technical difficulties. Please bear with us as we try to restore connectivity with Dr. Steffes.
Okay, the wonders of technology. We just dropped our connection here.
Yep, thank you.
So next slide, please. Next, please. There is no one perfect design. It's not like you can look this up in the book and grab something, but this is an OR design that we're not going to be able to see in great detail. It will be something that you can look at, though. But one of the things that I want you to notice that this is a 4 operating room central system here. You can see in the middle, just to the left of the middle, you see 4 operating rooms and then a horizontal longitudinal central core. and then all the other rooms are all the way around it. Now, the bottom right, for example, is where the outpatients come into the room, and on the right in the middle is the PACU unit where they go back out. And we have all the other needed rooms with this, and with the doctor's lounges and the nurses' lounges up at the top. You have various storage areas. So this is an excellent design. You'll notice that the hallways are wide. You'll notice that the doors are doubled, at least going into the operating rooms as well. And so the nurses and the doctor's lounge, you'll notice, have their own separate access. So this is an excellent design that is a really great one to borrow if you're going to do a 4 OR. Now, the only thing that's a little bit problematic about this design is it's not easy to expand it. There's no easy way to add another 4 operating rooms. You probably would have to do something like on the left-hand side, take out that wall, take out those rooms, and expand in that direction. Next, please. Now, we talked about this that workflow area, and again, I keep coming back to this because this is important. I am actually a very strong advocate of using ceiling supported arms, but they're somewhat difficult to get in the world where we live. Next, please. One of the things that you should do is, okay, if you're going to be doing minimally invasive surgery, how are you going to convert that to an open case? And so one of the things that's important here is where you're going to put your monitors. We have traditionally put them on tall towers. We put them on a series of carts. It can be an absolute structural disaster. The ceilings do have to be 10 foot, and the architect has to spend time making sure that the support beams are in the right place so that we can avoid columns. I've seen actually columns in the operating room. What a disaster that was. But the lights have to be high enough. The lights have to be able to move around so that you get full flexibility out of them. And again, remembering that it's always desirable to have more space than not. As a general rule, nowadays we're looking at a 16 by 20 or a 20 by 20 room. But if you're going to be doing orthopedics or some area that has a lot more of equipment, it might literally be 24 by 24 in terms of feet. Next, please. One of the things that's critical, we're always worried about sterility, of course, in the operating room, but then we have all this stuff sitting around, stored, and we often use some sort of surface which allows for dust or bacteria or mold or gunk to get in between all the cracks. So, for example, the finishes in this operating room should all be durable. They should be chemical resistant because we're going to be splashing disinfectants and those kind of things around them. On the bottom, for example, we should never have the floor meet the wall at a 90-degree angle. It should be coved. It should be coming up on a curved area so that we don't have that crack all the way around. Ideally, we would never use tile on the walls. You're much better off with an epoxy paint than you are with tiles because, again, as the mortar cracks, those just become areas where the bacteria can get in. And we really don't want to store equipment in these rooms any longer than necessary. And between cases, ideally cover them with some sort of cover, either cloth or plastic, because we don't want dirt getting down inside the equipment. And it's really difficult to clean this. So things should be stored out of there. They should be cleaned out of there. One thing that I've seen so often is the use of suspended ceilings. It's a good thing that Charlene Gilbert's not here. She'd have a hissy fit right about now. Those are awful in terms of cleaning and stuff filtering down from them as well. So the ceiling needs to be equally smooth as well. And all of this would obviously have an effect on the infection rate and also turnover. If I have to keep cleaning all this equipment in between time to do it right, I'm either not going to do it, which is going to affect my infection rate, or it's going to increase my turnover time because I'm going to waste a lot of time cleaning. Next, please. Windows in the operating room. Now, I realize that we're often in situations where power is very questionable, and we often do put windows in the operating room just so we have enough light to continue if we need to. And I certainly may remember one time when I was in the old Soviet Union that somebody was literally standing across the room with a mirror trying to focus it into the wound. But what is absolutely true is that these windows should never open. They should have some other solution for light and ventilation if you need it, but not open windows, because again, I've chased birds out of the operating room. If you don't listen and you do put windows in there, make sure they don't open. Don't use curtains if you can help it, because those are going to have to be cleaned regularly. They're going to have to be cleaned easily. The Windows systems that have built-in shutters and blind systems would be ideal, but of course, they're rather expensive even here in the United States. And it's much better to have good air conditioning for your ventilation. Again, making sure that your points where the electricity come out are, where the air comes out is not right over the table. Next one, please. Now, I'm a strong believer in, I've never had enough storage, but I've also never had enough electrical conduits as well. And one of the things that we're going to find is, as our technology changes, there may be a need to run more conduits. So running empty plastic conduit is important in the walls, makes it much easier to just drop a cord down through there for any new technology. Put in lots of plugs. And if you're going to be dependent on equipment coming from World Medical Mission or from North America, make sure you've figured out a system that will allow both a 110 and a 230 volt. And it's actually cheaper to change the plugs than to make the mistake of having somebody plug in the wrong thing into the wrong voltage and frying it. So if you're going to have two different voltages for those equipment, have two different plugs. That makes more sense. Ideally, we're going to run our suction and our gas piping for oxygen, nitrous, etc. from the ceiling. If you have the luxury and can get condensed nitrogen for the various gas-powered instruments and so forth, that's fantastic. If you're going to be doing hair clipping in the operating room, have a vacuum. Don't let that hair go wandering around. It turns out that most folks think you cannot sterilize hair adequately, and if it gets in with the instruments and you don't see it, it's going to be a contamination sterility issue. Next, please. Again, as we mentioned, in the operating room, there's going to have to be both sterile and non-sterile. I like to put the cupboards literally through the wall so that the people in the central core can open up the glass doors on one side, put the equipment in, and then the people in the operating room can open the doors on their side and get the equipment out. That keeps them from going in and out of the operating room and getting turbulent airflow that you don't want as well. And it's more convenient. We've already mentioned that you're going to need some place to store, pillows and sponges and clean linens and all the area. You should have some sort of X-ray reading area in this area, either a light box, or if you're lucky enough to have digital film, each room will need a screen. Next. Next, please. In the operating room itself, what do you do with contaminated instruments? Well, there should be two components. Number one, a linen hopper, just a bag on wheels that you can put dirty towels and dirty sheets in there. There should be some sort of ring stand that holds the basin that contains water. Point here, not saline. Salt is not good on surgical instruments. This should be pure water, and later on, consider adding detergent to it once everything is contaminated and you're going to hand it out. So at the end of the cases, all the instruments are going to go into that contamination. Sometimes I've seen OR teams try to save instruments they didn't use. By definition, they're contaminated. You can't just re-sterilize them because you didn't use them or touch them. You want to put those all in the basins with the fluid, and you're going to put your suction containers, your tubing, etc., on that cart, cover it with a sheet, and then roll it through the external hallway to the sluice area, the decontamination areas. And then ideally, the OR tech would take care of handling the fluids into the hopper in that area. Next, please. In the decontamination area, as I mentioned, they're going to be all covered with personal protective material. All the fluids are going to be dumped into a hopper. The dirty linen are going to be in a dirty linen area, usually with its own outside access. The biohazard is going to be stored as well, again with its own outside access, so that we don't drag this stuff back through our semi-critical areas. Next, please. After you cleaned it, you compressed it, You've irrigated the living daylights out of it. You put it in the ultrasonic cleaner if you've got one, and then you're going to put it in the washer sterilizer. As I mentioned, this is going to go through the wall into the clean area with the dirty things loaded on the decontamination side and the clean instruments taken out on the clean side. Next, please. So here's kind of an example here. The decontamination is that horizontal area just below the midline there, and you can see the various equipment and supplies and hoppers and so forth that are listed there. The one thing that between those two, between the decontamination and sterilization, that is actually should be a half door right there. It looks like kind of a wall, but it's not really. It's a half door. You don't want people walking from sterilization into decontamination area. You don't want people from decontamination walking into the sterilization area. You'll notice here that they have a storage that goes to the outside for the trash and the dirty linen. And then as you go up in the top, that's going to be the packing area. And you'll see they have only one autoclave. And most of the time, honestly, if you can afford it, you need two autoclaves, because as you get busy, you make the mistake of not allowing the instruments to dry for sufficient periods of time. And if they don't dry, they're not sterile. And so you often are better off with an extra sterilization unit. And then, of course, once they leave that area and they've come out of the sterilization, they're going to be moved to the sterile supply. So this isn't entirely ideal, but it gives a point of what we're trying to say. Next, please. Here is that, we put a little bit more detail here. This is that wide pass-through window and the counter. And what they don't show here, between those two counters, you see the one with the sink above and the thing below, there's actually should be a machine going through there that's going to wash and sterilize these instruments. Next, please. The clean instruments and the packing trays are physically separated from the decontamination area. In this case, the clean trays are clean areas interposed between the two. You should be able to get access from the non-critical areas to this area. There should be adequate table area and surfaces. One of the mistakes that we make is we often don't give them enough room to work. And by the time you fold some of these 3 foot by 4 foot instrument pack wraps, you need some room around. So make sure you have adequate space. And then, of course, within this is going to be storage for linens, disposables, any equipment that you're going to be included inside the pack, gauze, etc. Next, please. The sterilization area is where the large autoclaves are. Again, as we mentioned, we really want one. We do want wire rack areas so that they can dry adequately if we have to move them out. So we can move them out and cover them and let them dry. A wet pack is not sterile by definition. And then, of course, once you get into the sterile supply, it has to be where you can store the equipment, because they're going directly from there to the semi-critical hall and then onto the operating room. Next. So that's where we are. Lance, do we have any questions?
Well, thank you, Bruce. That was an excellent presentation. A lot of clarity, a lot of practicality. I know I have one primary question, but I'm going to wait a few minutes. Timothy Barant has a question there. He says, first of all, excellent presentation. Bruce, what are some of the most common or acceptable compromises or adaptations that you see when designing operating rooms in more austere environments?
That's problematic, because we still have this kind of mentality that we can operate underneath the mango tree, and that's but that's not going to get you your best results. And the reality is in an austere, especially when we're responding to some international disaster, we don't achieve the best results. And so sometimes we do make these compromises that are, quote, good enough, but they're not to be confused with excellent. And so the principles that we talked about still have to be held to. We all kind of laugh about the red line on the floor that the bacteria don't cross, but it's really there, honestly, for our own mindset, I guess, if you will, that, once I cross this line, certain things are acceptable or not acceptable. And I think that's important. So what you have to do is, there's not a single set of good compromises, because by definition, they're compromises. But you do the best you can under the circumstances.
All right. Okay. Thank you. Bruce, Marvin Haig says, can you say something about cesarean delivery and neonatal stabilization as they relate to OR design?
Um, if you're using an operating room that is in the actual main operating suite, that if you had one that you would dedicate to C-sections most of the time, then certainly have an area where you can do good resuscitation, where you have the suction and the oxygen and so forth, is an excellent thing to keep in mind. In many situations, they can't have a separate OB room because you just don't have the anesthesia staff to do that or the nursing staff to do that. So you do it in the operating room. But I think knowing that you're going to and taking the time to have all of the equipment that you need to resuscitate that child, perhaps in a rolling cart, perhaps in a closet, but it's not a place to go looking for suction tubing or go looking for oxygen tubing or go looking for the bag valve masks or anything. It's got to be pre-designed. I think this is where this workflow process that we mentioned is so critical.
Right.
Where are we going to do it, and what do we need, and where should it be stored?
Right. Awesome. Okay. Any other questions for Dr. Steppes as we conclude our presentation? While we're waiting, Bruce, I just wanted to say, from an internist to a surgeon, I appreciate your expertise on OR design. I hope, speaking on behalf of Samaritan's Purse, I think there's great application both from the World Medical Mission side with regard to our mission hospitals, and then the DART disaster response side as well, with design with our emergency field hospital. I think there's a lot of application with regard to both of those disciplines. I guess my primary question I had for you, Bruce, is one of just practicality. As you've alluded to, both you and I, even as an internist, when I go and visit some of these mission hospitals, I see some operating rooms that are very questionable in terms of design. What can we do? And I'm sure this is the $1 million question. What can we do to take this expertise and apply it to mission hospitals so that there is more, I guess, preemptive thought with regard to OR design?
Well, it's like most things. Nobody does anything badly because they want to. It's because they haven't thought it through. I think one of the things that's important is to go around through the operating room with people that know what they're doing and what it should be, and see what solutions we can come up to improve some of it. It's actually something that Charlene Gilbert is very interested in doing. She has a small foundation that works with an accountant, and with her 50 years in the operating room, she can walk in and say, that's not right, that's not right, that's not right.
Right.
She actually has the ability to, working with her architect, to help with design or even redesign. Now, unfortunately, as you're well aware, redesign and refurbishing is expensive, but sometimes it ends up being the only reasonable option to bring it up to the next standard, because there's two things here going on. Number one, if I'm getting a lot of wound infections or having problems with wound infection, it increases the amount of money to run the hospital. It's bad on the patients, and it's bad on the hospital. If the other thing is if I'm having complications of this, I do what I do to honor Christ. And if I'm not doing the best I can, I've got a problem with that. And so those are all issues. But if you wanted to either email me or to email you, we can put them in touch with Charlene and her group, and perhaps they can help. They're small, but they're very eager to help and have a lot of expertise.
Right. Well, I'm certainly familiar with several mission hospitals currently that are in the process of upgrades and expansions with regard to their operating rooms. And certainly we will get the word out, Dr. Steppes, about yourself and Charlene Gilbert and their y'all's availability. So, Bruce, I think that's all we have with regard to questions. Again, really want to thank you for your time and efforts. I know you're a busy man, and so thank you. To our listening audience, I just want to say, remember that CME credit is available for this session. The form and instructions are written out on your email, and we will be sending a follow-up email with a link to this recording. Remember, when you go to health.samaritansfirst.org, there's an incredible archives of these webinars available to you with CME credit. So just encourage you to visit that website to explore various learning opportunities there. Next month, Wednesday, May the 8th, please join us again for another forum. Dr. Jordan Rupp, who serves at Vanderbilt, is an ER physician, and this is kind of like ultrasound part 2. Dr. Peel presented several weeks ago. Dr. Rupp is going to be presenting follow-up with lung ultrasound. So that's an up-and-coming technology that's just becoming more and more widely available, and the technology is improving dramatically. So just encourage you to join us. And then finally, I just want to promote PFR prescription for renewal. It has really been going on for about 30 years now, but because of the growth of the medical sector here at Samaritans First, PFR prescription for renewal will be moving to Orlando, Florida. We will be hosting at the Renaissance at SeaWorld. Please look at the Samaritans First website. That will be September the 19th through the 22nd. Incredible opportunity to engage yourself with the various opportunities with the medical sector at Samaritans First. So I hope you will put that on your calendar and join us at PFR. And with that, that concludes yet again another Samaritans First International Health Forum. Thank you for joining us. God bless.